Welcome to the Implementation Toolkit for Small and Sick Newborn Care webinar. Hello, everyone. Please introduce yourself in the chat. We'll have this webinar translated as well in French. Next slide, please. Welcome to the Newborn Toolkit Joint Learning Community. Our aim in this series is to encourage collaborative learning for faster progress together for small and sick newborn care. This year in 2024, our webinars will be structured around the WHO UNICEF 10 core components of small and sick newborn care. Today's topic will be focused on the leadership and governance core component, and the topic will be speeding for neonatal survival, learning leadership from fast progressing countries. We'll hear from China, Malawi, and also get a perspective from the civil society in Brazil. On the screen at the moment, we have QR codes for our Newborn Toolkit newsletter. Please do subscribe. We have it in French as well. And also please follow us on our social media channels where you will hear about webinars, news, and we'll share tools and ideas in small and sick newborn care. Next slide, please. All right, and I'm honored today to welcome our host, Prof. Chinyere Aziaka, neonatologist at Lagos University Teaching Hospital, NEST 360 clinical lead, past president of the Nigerian Society of Neonatal Medicine, and a member of the African Neonatal Association. Welcome to our webinar, Prof. Chinyere. Please, and I'll hand over to her. You are muted, Prof.
Thank you so much, Mbozu, for that kind introduction. Yes, we're welcoming everyone to the very first session of an exciting on the Newborn Toolkit, the first for 2024. And today, next slide, please. Thank you. Today, we'll be looking at learning from countries that are speeding up with neonatal survival. So the title today is Speeding Up for Neonatal Survival, Learning Leadership from Fast Progressing Countries. And we're also speaking about the, trying to let everyone know about the Toolkit series that today's on is for 30th January 2024, and we have other exciting coming events. First of it is the one for 20th of February, where we want to speak about keeping equipment out of the graveyards for small and sick newborn care, looking at implementation realities for maintenance of neonatal devices. And now the second is for 19th of March, speaking of for newborns everywhere. The toolkit is now translated in French, and you will be hearing from our French colleagues on the 19th of March. So welcome everyone to this exciting session today, where we're learning from countries that are making great progress. Please introduce yourself in the chat. Bienvenue. Voulez-vous introduire dans le chat? So I will hand over now to Lauren to speak about this French translation as we sit back, relax, and hear from countries that are making great progress to aid in our speedy progress for small and sick newborn care. Over to you, Lauren.
Merci beaucoup, Chinyere. Alors, bonjour et bienvenue à le webinaire. Si tu veux écouter le webinaire en français, s'il vous plaît, cliquez sur le bouton de la chaîne française affiché en bas de l'écran. Merci.
Thank you very much, Lauren. Our French colleagues, bienvenue, bienvenue. So now we'll move over to our first very eloquent, renowned speaker today, Professor Joy Lord, who is an African-born, British-trained pediatrician and perinatal epidemiologist with 30 years experience, especially in sub-Saharan Africa, including clinical care, UN epidemiology reporting estimates, implementation and economic trials, and evaluation of maternal and newborn care services across board. Prof. Joy Lord will be speaking to us today about status for neonatal mortality rate progression and national policies for small and sick newborn care. Joy, you have the floor. And
Thank
she's a
you.
clinical, yes, and she's also one of the Born2See team members. Over to you, Joy. You're welcome.
Thank you,
Thank you.
Chinyere, and thank you, everybody, and wonderful to see such a fantastic group here and a very exciting lineup. I want to just start from what our scores are for maternal, newborn, and child survival at this point. And here we are, we're now more than halfway through the Sustainable Development Goal era. We still have almost 0.3 million women dying needlessly each year, 2.3 million neonatal deaths each year, 1.9 million stillbirths, counting just from 28 weeks of gestation. So together, this is 4.5 million deaths, each one an individual and each one affecting many in a family, but also lost potential for countries. And critically, these now account for more than half of deaths for reproductive and child health outcomes, more and more close to the time of birth, and we need to ally together. So as we're looking at leadership and governance and policies, two important policy documents for speeding up progress for maternal, newborns and stillbirths are these two action plans, the Every Newborn Action Plan and the Ending Preventable Maternal Mortality Plan. And both of these link to Sustainable Development Goals, which all of our countries have signed on to. But having policies is one thing. How do those really link into action? So each of these two policy groups have worked together to have joint targets for coverage of care. And if we look at all the things that have moved fast in the world, immunization, progress for reducing HIV, these have coverage targets for how many people need. So these joint coverage targets were set in 2020, actually with a target for 2025 for antenatal care, skilled attendance, postnatal care, and then that 80% of districts should have a newborn care unit that works and an obstetric care unit. So these are joint milestones that most of our governments have signed onto. Globally, there's a joint group that looks after these together. So we're not competing between maternal, newborn and stillbirths. They all matter. And that there is ongoing work with wonderful leadership by WHO, particularly now Queen Dubé, by UNICEF, particularly Gagan Gupta, and also from UNFPA. And this is important for us to know about because in each of our countries, these UN offices are really working on accelerated plans to try and speed up progress. And what can we then do for the neonatal part? So for the rest of this webinar, we'll be particularly focused on neonatal. So the good news is that for the first time in history, we have a global target for newborn survival. So from 2015 to 2030, we have this Sustainable Development Goal target. And the target is that every country should reach a neonatal mortality rate of 12 or lower before the year 2030. And it is fine for countries also to set their own targets. So for example, Prof. Chinyere is here from Nigeria, which has a target of 15. The key thing is to have a target, know what it is, know what your target is for your country and work towards that. And it's really fantastic news that based on those 78 countries have now set targets, there are 106 countries that are regularly reporting on those targets and the coverage targets to the UN. That's the good news. The less good news is that 63 countries are off track. And for many of the countries that are off track, particularly those that started with higher neonatal mortality rates, they need to more than double their current rates of progress. Some countries, it's even considerably more than doubling. So for Nigeria, would have to go about tenfold faster, which is an incredible acceleration that would be required. So what can we learn from others? So this is a really interesting paper, and I don't know how many of you will have seen this. Maybe we can post the link in the chat. which came out at the time of IMNHC last year. And it's looking at countries that have made progress for maternal mortality on this axis, and stillbirths and neonatal deaths on this axis, starting from high mortality, going down to low mortality, and looking for important markers of change. And particularly here, birth in a facility and higher quality birth is important. But a big message out of this paper is, as you go forward from high mortality, each time the step takes more. You cannot take for granted that past progress will lead to future speed. And it'll be really exciting when you listen to the China story coming up soon on how they maintain that. Each step, you have to do more to go further. So if we think about this, particularly for the newborn, so what this graph shows is neonatal mortality on this axis, and time starting from 1900, so historical data. And this is the UK and the US, but we can also look at Norway and many other similar patterns. And if we look at where we are now, for most of the deaths, so about 3/4 of the births and the majority of the deaths are in sub-Saharan Africa and South Asia. And if we look at these two continents, with a neonatal mortality rate of around 27 and 23 and getting to 12. This is very steep. And if we look at the speed that was taken in the UK and the US to get from 27 to 12, it was a long time. We need to go faster. And we have more in our hands. We have more innovations, more opportunities, and indeed neonatal care, even from the time I practiced it in the UK 30 years ago, is de-intensifies. So the worlds have an opportunity to meet. These first phases of mortality reduction, it's possible to do more at home, and it's possible in some ways to go faster with easy things. But once we get down to kind of the mid-20s for the neonatal mortality rate, we have to do more with high quality maternity care, neonatal care. And once we get down to about 15, we really have to be transiting towards neonatal intensive care. So if we look at learning from countries, the fastest progressing country in the world is China, moving at more than 8% per year. And China made this transition that Southern Asia and Sub-Saharan Africa need to make in about a decade. So it's really critical to learn from China, and they've got a very exciting talk come up. And really interesting to see how that was done. Importantly, also within Africa, we have our fastest progressing neighbor, and we will be hearing from Malawi, now at a neonatal mortality rate of about 19. But if we look at what has been done in all of these and all the fastest progressors, this is all the UN member states in the world, so all these countries, the number of countries in each of these neonatal mortality rate levels. So 71 are already below 5. If we look at the highest level, there are no countries that are in that level, but there are subnational populations, especially with humanitarian contexts. If we look at this next highest level, these are places often with humanitarian challenges. And this is where most of the world's births are, in the 15 to 30. But we need to shift most of these into the 5 to 15 to be able to reach the Sustainable Development Goal. So important to learn from each of our neighbors. And I want to flag the exciting progress in India later. But first of all, to give you an overview across all these countries of where we are for policies. So a really useful way to understand these policies is from the Every Newborn tracking tool, which has been ongoing since the Every Newborn Action Plan was launched, because it was intended to be a country action plan. There's been active work with countries to see how they're doing. And it started with a small number of countries, has really grown. And then excitingly, with the International Maternal and Newborn Child Health Conference last year, This tracking tool incorporated and partnered and integrated with the maternal health community, so revised the tool, and the number of countries that were tracking increased. And here I really want to give a salute to Dr. Gagan Gupta at UNICEF, who led the work to revise this tool, integrate it, and to lead the outreach to 106 countries to reply. So what can we learn from this on countries' progress for scale up of neonatal care? So if we're zooming in on the neonatal care, really critical to get to a neonatal mortality rate of 12 is impossible without neonatal care, including respiratory support. So if we look at this across all these countries, there were 95 countries that responded to this tracking tool. Around half have a target to reach 80% of districts with a functional neonatal unit. So a gap in leadership and policy at national level. But there are many more in Central and South Asia that have those policies. And for those of us who are based across Africa, it's really important to support and work with our governments to help them to have a clear plan for reaching 80% of districts with a functional unit. And then if you look at this reported data on those who say they have met the target, there's about 8 countries in Central and South Asia. Within Sub-Saharan Africa, there are about 4 countries, and this includes Malawi that we will hear from later. So a message here is to find out, does your country have this plan? How can you support this plan? And often for those of us maybe who are clinicians, we focus on a center of excellence where we are, but to change impact for newborn survival across a country, we need to reach every district. Then if we look at the money, which is the real driver, yes, you can have a plan, but is the money coming in? So this is report data, and importantly, it's linking maternal and newborn health. So it isn't necessarily saying, have you got separate money for newborn health in the plan or in your allocations? But there is a question on a budget line for small and sick newborns. Does that exist? Can it be tracked? And at the moment, only 22% of countries have this. So it's hard to track how much money is coming for small and sick newborns. But even if it's hard to track, we know from other webinars and papers that we have studied together on the toolkit that there isn't enough money. Newborns are still newborn on the agenda, and in fact, it's even lower for stillbirths. So we need a plan, we need money, but we need to implement. And to implement, it isn't one thing at a time. We can't just run a training and assume that things will change. We need to have different components. And WHO and UNICEF have put together these 10 core components for small and sick newborn care. And as Mbozo said at the beginning, this year we will be having an exciting series learning together, really to support WHO guidelines so that we take that into action. So what do we know about leadership and governance, about the money, about infrastructure, medical supplies and devices, and so on? We'll be working through these together. And if you look at the toolkit now, it's been reorganized to enable us to learn together. Please do share your tools and your learning, and also look to see what is here already. So if we look across these countries who reported, 95 countries who reported, what do they have for these 10 core components? So almost half have a strategy. Anything that is red is less than half. Anything that is orange is between half and 3/4. And in fact, it's actually really encouraging to see that the one thing that is in green is linkage to maternal care. So clearly for newborn health, utterly fundamental that we link with maternal. It is a bit discouraging, as we said, about the money, and important that we learn how to make the case for that better and how to ensure that the money we have reaches where it will have most impact. Standardized floor plans are a gap, and WHO are working on norms and standards for this at the moment. But meanwhile, there is also floor plans that you can access on the toolkit. Norms and standards for HR, also critically coming from WHO, but meanwhile also things that we can learn, especially for the importance of neonatal nurses. So these are all components where we need more work. And I want to finish with the exciting story from India before we pass on to learn from other countries. So Gagan Gupta couldn't join us today to talk about this, but India has had this dramatic increase in the number of neonatal units. And excitingly, in the most recent years, so the last 3 or 4 years, they're now seeing a reduction in neonatal mortality rate that is now running at 4.6% per year. So really speeding up the progress with this comprehensive approach, not just having more neonatal units, but with multi-level investment to have workers and really ensure that these are providing care and also collecting data that is used. So I want to end with a few key messages that we learn across all these countries before we dive into more detail. So importantly, government leadership, having a plan. Most countries have the Sustainable Development Goal, but they won't meet it without this plan for small and sick newborn care. Needs more money and how to make the case for more money, particularly infrastructure, because if we're in tiny rooms with no power, no space for nurses, and not respectful for women, we won't get impact. How to use evidence and share learnings, and here we really encourage you to join and share your learnings on the toolkit. And then partnerships, very important to include parents, as well as professionals and parliamentarians and others. So we welcome your ideas, suggestions in the chat, and I'm going to pass back to the wonderful Professor Chinyere to introduce our next speaker from India. Thank you so much.
Thank you very much, Prof. Joy, for that excellent presentation. Most of the deaths are in sub-Saharan Africa. We need to go faster. But how do we learn from countries that are moving very fast? And now we want to take a zoom at China. That is the fastest overall. And to speak to us about China is Professor Yuan Wang. To introduce Professor Wang, she is an assistant professor working in China's National Clinical Research Center for Obstetrics and Gynecology, that is the Peking University. Her research fields include maternal and children's birth cohort studies and clinical trials. She's also working on national data surveillance and analysis and public policies related to reproductive health. Professor Wang today is going to speak to us during this exciting webinar on fastest progressing countries for neonatal mortality rate reduction, with China being an example of it. And I'll hand over now for us to hear from Professor Yuan Wang.
Hello, Professor Joy Law. It's my honor to share some points and the data on this very important topic, China's neonatal mortality reduction, always on the road. From this picture published by Professor Joy Law and her team, China has a rapid decline on NMR. The new figure is 3.1 per thousand in 2021 and 2022. From China's rapid reduction on NMR, we can summarize 4 key points. The first point is strong social consensus. In China, according to the traditional culture, children are considered as the heart, the center, and the future in a family. Most people would like to put more resources to children's health, education, and future development. The second point is the top-down government commitment. From 1992, the government launched the 2 outlines of women's and children's development every 10 years. The 2 outlines is a KPI for the government at all levels. In the 2 outlines, NMR and MMR are 2 very important key indicators to be used to evaluate the performance of the local government and its first leader. If the NMR or MMR is not controlled well, the first leader will be fired immediately. This rule seems unreasonable, but it does successfully promote the local government to put more resources on improving maternal and neonatal health. The third point is, over the past 70 years, China has continued to establish and improve a hierarchical maternal and child health system. Each province, prefecture, district, or county has a special institution to manage all maternal and child health services in the area, from hospital to community, from urban to rural. The first point is, China always used step-by-step approaches according to its available resources at different stages. Here, in my personal opinion, I would like to divide them into 4 stages according to the main targets and the covered skills. In the first stage, the main approach is promoting hospital delivery, but only limited to some pilot programs in rural areas. In the second stage, besides the hospital delivery, the main approaches also extended to improving pre-pregnancy and prenatal examination, nutrition, and basic medical skills. At this stage, the government carried out a lot of national major programs in rural areas across the country. We can see that in the first and second stage, those programs were mainly conducted in rural areas, and the main target is to reduce the big gap between rural and urban. In the third stage, the main approaches extended to build a community-based primary health care system, community hospital referral system, and IT system. At this stage, all approaches has been integrated into national basic public health programs and carried out all over the country, covered both rural and urban areas. In the first stage, China started to promote 5-level pregnancy risk assessment and management, and also built a lot of maternal and neonatal ICU centers and the referral system. At this stage, China wanted to establish a comprehensive maternal and child health service network all over the country. Here, I want to point out the special contribution from many NGOs such as WHO, UNICEF, World Bank, Gates Foundations, and so on. Those NGOs play an important role to help China build its maternal and child health care system, especially in early years. Here, as a new mommy, according to my personal experience during my pregnancy, I draw this flowchart to show the current maternal and child health services network in China. We can see that at different stages, from pre-pregnancy to postpartum, the community and the hospital provide different services to take care of pregnant women and their babies. Also, if there is any maternal and neonatal near-miss case, the hospital can quickly transfer them to a nearby maternal and neonatal ICU center. Up to now, the number of such centers in China has been over 6,300 in total. At last, although the time is limited, I also want to give a brief talk on some new challenges on maternal and neonatal health care in China. Over the past 10 years, China's newborn number has declined very quickly. Does it mean that China will have less power to control its neonatal deaths? The answer is no, totally not. because there are also some new challenges related to neonatal health risks, such as advanced maternal age, declining fecundity, assisted reproductive technologies, pregnancy after C-section, and so on. All those conditions will lead to a higher risk of sick and small newborns. So China must continue to improve its maternal, neonatal, and child health care to ensure new babies' safety and health. Okay, that's all I want to share in this part. Thank you all for your time. Thank you.
Thank you very much. Thank you very much all. We've just had an enlightening session from Professor Wang speaking about China's journey to being the fastest overall in the care of small and sick newborn. Now we're leaping from China to Malawi to hear from Dr. Sandeni Shwime, who is a Chief Pediatrician of the Ministry of Health of Malawi, and she is also the clinical lead for the Next 360 program. Sandy will be speaking about Malawi's progress, being the fastest progressing in sub-Saharan Africa. Over to you, Sandy.
Thank you very much, Prof. Chinyere. And as you quite rightly said, I'm speaking on neonatal mortality rates in Malawi and looking at this graph that takes us from 1990 to 2021. So you look at the amount of time that it took us as Malawi to move from phase 1, which is the highest mortality, it's about 5 years, more than 45 to decrease that. It took us double the time to get down to phase 2. And it's more than double, 20 years more than, for us to work on our current phase, which we're still in, and we are hitting 19 at the moment. But we want to take a moment to celebrate that fastest reducing neonatal mortality rate in sub-Saharan Africa. And I can see a couple of Malawian colleagues here. If you are there celebrating, 1 second, just type yes for Malawi. And we are celebrating that because there's been a lot of hard work that went into that. Nonetheless, we still have to get down to 12. And that requires us to give 5.3% per year for us to hit the 2030 target of 12. So we still have to double down our work and really make sure that we're doing everything that it takes. Next. So as a learning from this, looking at the phased approach of neonatal mortality, we want to understand what exactly happened in Malawi for us to be making that decline. So for the first phase, this was before the MDG era, the real focus policy-wise was the child survival, and really the programmatic approaches were primary as healthcare centered. So provision of good family planning, good immunization techniques in the communities, focusing on nutrition for both for the babies and for the moms. In second phase, there was now a bigger focus on maternal and child survival. And this, the programmatic focus was then to increase antenatal coverage and targeted interventions, for example, PMTCT, preventing mother-to-child transmission of HIV, and other interventions. And at that point, we began shifting from births happening in the communities or in the homes to actually facilitate births and stronger maternity care. The phase we're in now, which began in 2005, we actually stopped as a country and did a situation analysis to understand what the challenges were. And we learned that maternity care has really shifted at that point. A lot of births now, over 95%, are really happening in the facilities, no longer in the communities, which is so great for us. But we still need to focus on work on the quality gaps that exist. These are very crucial for us to focus on, for us to see some change. There's a good practice of resuscitation in our labor ward, and there is a good foundation to KMC. Most facilities are providing, but still, even on the newborn component, quality is an issue that we still have to dive in as time goes by. Then as we went along around 2015, thereabout, our postnatal care services improved. We now have health surveillance assistants that are going into the communities and providing care to these babies early on. And then now we actually have neonatal care improved in the facilities, not just maternity care improving. We're starting to improve the actual neonatal care. We're starting to provide more and more CPAPs in our facilities and also increasing KMC. We have the whole hub and spoke model for scale up with multiple partner inputs, which is a real big opportunity for us. Has started well, but really needs force for us to move on and decrease to the next level. So nationally, we have been able to provide quality newborn care in 27 districts. One district is a hard to reach district, and therefore we couldn't say we've done much. But in the 27 that are accessible, we have provided 37 newborn care units, which is excellent for us. Next. And then, but before we go to the districts, or even at the start of the program itself, we did a health facility assessment. And we learned quite a great deal from this assessment. We learned that our policies are very strong and our governance and leadership is very strong, depicted by this green that you can see there. We learned that we're still, in average, we're still working hard to get the overall performance up to speed and struggling, but doing quite a good job on HR infrastructure and health information system. But terribly struggling is the family-centered care piece, which is a huge focus for us in the next agenda. So what we're learning is really that we need these high coverages on the interventions that we need to get the impact that we require. So we need high coverages, but also good quality of provision of these interventions. For example, provision of CPAP, but also thinking through getting most of our babies warm. So most of our babies are really cold on admission. So we need to bump up our work and improve these indicators for us to see the outcomes that we're looking for. And all this is being done at the moment with a support of a data dashboard and a QI team that's going around and together working with the teams on the ground and understanding their data and planning next actions for improvement. As depicted on the picture below here, you can actually see the team in a facility who initially had a paper-based data, which can be quite difficult to follow through and act upon, have actually now got electronic systems where they're reviewing their data and using that data to create actions that are feasible for their community and for the facility. So what are we saying really from Malawi? What should you take home? What we should take home from us is that there's actually good governance in Malawi. We have a one plan, which is government-led, with multiple partners that are speaking into that, and the District 60 is one of those. But there's still quite some gaps in the funding of the small and sick newborn. So we'd like to really push more on that, and with a serious focus on infrastructure and human resource. So we also are updating our newborn action plan, which is intended to therefore link to this one plan that is government-led. And hopefully together we drive more changes towards newborn care. What we've learned from this discussion and what I've shared is that, as you know, there's a WHO target that we must improve, provide small and sick newborn care units in 80% of the districts. And we want to say that Malawi is proudly saying that it has done that in more than 80% of its districts, and probably why contributing to such a decline in mortality. But we still need to get good coverage and good quality in good interventions like CPAP and KMC. We also need to keep a systems approach when we're doing things and be collaborative. And at the moment, we've learned a lot by collaborations between clinicians, biomeds, QI directorate, and also using data for action. Like, for example, we have a dashboard using the Nested. So collaborative or team effort is what you should take home. And finally, we're really thinking into partnerships and including parent power. I think that's something we really want to embark on a journey. We have many partners at the moment that coordinate and support the government on its plans and stuff. But we need to get the parent groups really more active, and because we need power and we need to empower these parent groups. I think that's what I would like to say to you from Malawi. Thank you.
Wow. Thank you so much, Sandy, for this very exciting presentation. We join to congratulate Malawi on the great progress they have made. Sandy's last point on the parent power, the power of the civil society, dives us now to get to Brazil, where we will hear from Dennis Seguitani. Dennis is the CEO of a Brazilian Parents of Premise Association called Premature Day. Over to you, Dennis, the power of the civil society and accountability. Thank you. Over.
Thank you so much, Shanir, and hello, everyone. It's an honor to be speaking to you today. Congratulations to Malawi and China for their achievements. I'm going to talk about how we believe organized civil society can contribute to change the scenario of neonatal survival and neonatal health. And I'll bring some examples of what we have been doing in Brazil as so. So yes, we do have a key role. Organized civil society has a crucial role in not only accelerating neonatal survival, of course, but also ensuring that all babies have the chance to reach their full potential of life, to grow, to thrive with quality of life, and no matter where in our countries they are born. And especially those babies too small or too sick, we have to look at them with these special eyes. And we have a huge role in seeking equity in access to health for them, and also social justice for them and for their families. But why us? Why we need to take this leading role in all these processes? Because usually government can't meet all the needs of the population, can't reach all places. So especially in countries with large population and large geographical dimensions, such as Brazil and many others, the role of organized civil society, of parent groups, are very, very important. And also because in general, countries need to change their mindsets regarding the family's participation in some processes, such as building public policies, building a specific care guidelines or a research protocol. Families have to be included in all this. Nothing about us without us, as we say. And how can we do this? Well, there are a lot of ways, but of course, we have to walk side by side and work together with the government, making partnerships with stakeholders, other organizations in the field, always, of course, evidence-based. And it's important, of course, to raise awareness about causes and consequences of preterm birth, engaging population in general, calling for volunteers. And it's our role to go to media, to make some noise, to show the human side of these stories. This is a public health emergency, and we need to touch people's hearts with these real stories, what really happens with these families. And this is also identifying of opportunities for improvement, not only demanding action from the government, but also giving them what we think is the ideal solution, and make strategic partnerships, and of course, keeping always an open and transparent dialogue with other stakeholders. And about Brazil, we have an average prematurity rate around 11 to 12%. We have improved in the last decade, but these figures it still means that we have around 330,000 babies being born preterm each year in Brazil, what makes us number 10 in world prematurity ranking. And our organization is 10 years old now, and we are the only national organization working in Brazil for preventing preterm birth and also advocating for the rights of preemies and their families. We have around 400 volunteers all over the country. And there are two initiatives I would like to mention regarding this webinar. One is the extended paid leave for mothers of preemies and sick children. This was implemented in 2020. We were very involved in this. It took us 6 years of hard work, but it was a huge step for Brazilian society to have this law. And if you go to borntoosoon.org, you can read more about this initiative and other figures regarding Brazil and so many other countries. And the other initiative, it's kind of related to the first one, is what we call in politics here in Brazil, thematic groups. So they're groups, of course, of politicians who are willing to support a specific social issue. So in recent years, as well as having a good relationship with the Ministry of Health and other departments in government that are key for our cause, we have prioritized going to the Congress to raise awareness among parliamentarians and forming a prematurity thematic group. And this has made all the difference in changing the scenario, slowly, but changing the scenario of prematurity in Brazil, because when we manage to create or to improve a certain guideline or public policy, the entire population benefits, and that remains as a legacy for future citizens, for the children. And we are talking about a considerable and important part of our next generations, these babies that are being born too small or too sick. So yes, hands-on, because thoughtful and committed community activism can definitely be a game changer. We can change the world. So thank you so much, and please feel free to reach us for anything, any information you might need. Thank you, Shanira.
Wow, thank you so much, Denise. Nothing about us without us. The need for organized civil society, the need for us to amplify our voices for our newborns. Thank you so much, Denise, for that wonderful presentation that was quite enlightening. Now the audience, very distinguished participants. We've heard from our panelists, starting from Joy, who gave us the figures. We moved to China, where Prof. Wang excitedly gave us details about China's journey to being the fastest overall in the world for newborns. And then we moved to Malawi, where Sandani told us about Malawi's progress being the fastest growing in Sub-Saharan Africa in terms of newborn care. Now we also heard from Denise, adding that human angle. So now the floor is now open for questions, comments. How do we work together to learn from this exciting webinar today to improve in our countries? I'm looking out for questions, comments. Please post in the chat. Thank you.
So, Chinyere, there's a fantastic question from Anita Carr about what strategies could be used to mobilize support, and a similar question from Christina about guidance from Malawi on political commitment. So I wonder if we could ask Dr. Umsandani Chumi maybe to talk about strategies to mobilize government support for small and sick newborn care.
Yeah.
Thanks, Joy. Over to Sandy. Thanks.
Yeah, thank you very much. Christina, I think you raised an important issue about getting political commitment on maternal newborn care issues. I think from the beginning, the partners were very clear about embedding whatever they needed to do into the government systems. So I think that was a strength for us as Malawi. And we really applaud such, very reasonable people. So when we saw the proposal as Malawi government, it was what was required. We knew we had the basics, but we needed to move to the next level, and we needed support. And just having this opportunity through Next 360 to embed everything that they wanted to do on newborn care within the government structures was for us a plus. And therefore, anywhere where you sold this idea within the government structure, you did not find or meet any resistance. Everybody embraced it. They were ready to let go and allow us to teach the programs, to speak into the government challenges, to lead the program. And I think that in itself, that collaboration is what has led to this success up to date. So I would really applaud. It's both-sided. It's the partners being willing to let go and let the government lead, but also the government itself embracing. But also it's because it's really a need and it touched the right spot at the right time.
Thank you so much, Sandy. Still looking at the questions and the answer session. I'll move over to Joy to answer the next question that's on. Joy, please.
Yeah, thank you so much. And just to thank everyone for the really rich questions, and to underline what Chinyere said, I think government leadership is critical, and we sometimes then get asked what happens if your government doesn't lead. You know, how can you encourage that? And I think that's where knowing that you have a target for your country and holding them accountable, that some of the measures that Denise has talked about, so getting stories in the media, using things like World Prematurity Day, not just to wear purple, but to lead people to change. And then also that kind of wider partnership of parents and professionals can link with parliamentarians as well. And then sometimes knowing your neighbor is going faster can help. So all of those things can help. And there are lots of things on the toolkit to help you make that case. I would salute Tanzania, where a really fantastic partnership has led to extra money coming into neonatal health and a lot of new units being built. Maybe specifically on the question on congenital from Istra, thank you so much for that. And it's very important that we don't lose the congenital conditions. That's now around 20% of neonatal deaths, and also a significant number after the neonatal period. Sometimes we miss them. So we misdiagnose congenital heart disease as respiratory distress. So I think better diagnostics are moving forward with small and sick newborn care, getting the data. And then to have those surgical services, you know, is a next leap. So China, you know, worked both on the preventive side, for example, having folic acid supplementation, and more importantly, fortification nationally for prevention. But the care services, to have the surgery, you also need better neonatal intensive care. So, you know, as we go forward with CPAP and then moving forward to NICU, that's the time to bring in the surgery. And I don't know if maybe Denise, if you want to talk to that from Brazil, because I think both Brazil and China are further ahead with the surgery and support for congenital conditions.
Yeah, thank you, Joy. Our Ministry of Health have been looking at this very closely because it's a huge issue for us, as well as teenage pregnancy. But can I also answer, because I've seen a question from Mary Kinney in the Q&A, and I can also, it's related to what we were talking about. She's asking how we coordinate to work together with other organizations or stakeholders for limited resources. And yes, we try to, gather everyone because we have a common purpose. So of course, Brazil has a specific needs in each region is different. If in the same city, you have different realities in different hospitals or different health institutions in the whole country, it's huge. So we try to bring everyone together and then identifying specific difficulties or problems in this region, and then can divert the money or spread what we have gathered of support from the government and even resources for that specific region. I don't know if I answered your question, Mary, but feel free to reach me later.
Thank you so much, Dennis. Yes, you answered the question quite eloquently. We're looking at the top of the hour, getting to the top of the hour quickly, but we have 2 quick points I'm seeing on the chat. Alex asked about, do we have any idea how rough, no matter how rough, how much it costs to set up a district neonatal unit? And we just start off, Joy, we start off the answering this, yes. So and then I think Peter Bafwa has his hand up. This is a message from Mpozo. Yes.
Yes, I think maybe just on the cost, we will have another session on that, and we can post in the chat the paper that's just been published from Tanzania, which gives fantastic insights on that. And we will have another session on that. I think we can't take hands easily. But I think there was a very interesting question from Masira Mageni about family-centered care in Malawi. Maybe we could take that as the last one from Dr. Msandeni, who's offered to do that. And then Frank, we will try to answer in the chat.
Yeah, thank you. I think it was also asked previously what the challenges of provision of family-centered care were. And so one of the biggest hurdles or bottlenecks has been the infrastructure itself, in that it's not very permissive. It's most of the sites have small newborn care units, and women are walking around half dressed, making it uncomfortable for the men sometimes to come in and visit. And so being deliberate about things like that is the way forward. So, for example, we've reached out to partners, and we are having some access to now infrastructure funds, which will help us expand some of the centers to allow for better practice. And then also for some of the centers, even just starting small, because there are also some cultural context that you have to take into consideration. I don't think it's just a one answer. More studies are required around this to understand what the cultural contexts are, and also just to start by even just a simple lunch hour visit where the fathers can start coming in would be a step forward. So we're thinking a lot around this area, but I think for just off the top of my head, that's what I could say. Thank you.
Thank you, Sandy. Excellent question and answer session, answering that question very well on family-centered care, which is very key for improvement on small and sick newborn care. As we get towards the end of this session, ladies and gentlemen, thank you so much for your very great participation. Today, we've learned about speeding up for neonatal survival, learning from leadership from fast progressing countries, where we got the data from Joy, who gave us the data statistics and gave an excellent example of how India is making so much progress. Then congratulations to China being the overall, and great congratulations to Malawi for being the fastest in sub-Saharan Africa. And we learned about the parents' power from Denise, where in Brazil, the organized sector has been able to make government amplify their voices so that they got paid maternity leave for mothers of preterm babies, which was quite extended up to 6 months. So this is huge. We need to all come together and build the momentum around small and sick newborn care. I'll hand over now to, thank you so much for coming for this session, and we invite you for future webinars on the toolkits. And I'll use this opportunity to thank all the excellent panelists for the great work today. And I'll hand over now to Mbozu to speak about future webinars. Thank you so much, everyone, for your kind participation at this webinar today. It's been exciting and great learnings for all of us as countries to move forward. Over now to Mbozu, please. Thank you.
Thank you so much, Prof. That was a brilliant summary of such an inspiring and energetic webinar. Love to thank everyone again for coming and for being so engaged and asking all the questions that you asked to just increase on the learning. So we have 2 upcoming webinars on our website at the moment. So on 20th February, we have a webinar based on the medical supplies and devices core component. The title of the webinar is Keep Equipment Out of the Graveyard, Implementation Realities for Maintenance on Neonatal Devices. Please do add this to your calendar. It'll be a very exciting webinar where we can learn more about how to keep the wrong equipment out and keep the important equipment in the neonatal wards. And on 19th March, we'll have our first ever French-led webinar with an English translation. And the title of that webinar is Speaking Up for Newborns Everywhere, French Language Implementation Gap. So we really encourage our French speakers to share this webinar with your French colleagues and to maximize the audience and the reach of this webinar to improve on the learning in the French-speaking context. Next slide, please. All right, so as I highlighted earlier, and I'll just flag this now, we have a newsletter in English, a newsletter in French, and also we have social media channels linked to the Newborn Toolkit where we just want it to be a two-way platform where we share and learn together. So please do make use of our QR codes now on the screen, and we will see you all in February. Thank you so much.
Thank you, everyone.